lecture of Dr. Nuhad Ibrahim. He will talk to us about the future of adjuvant anti-HER2 duration and the new therapies.
Good morning. Thank you, Mr. Chairman, for this introduction. And also I want to thank the scientific committee and Dr. Ghazali for inviting us now on every year, especially this year because we had the chance to escape an ice storm in Houston, and we broke the record for 48 hours. We were colder than, in Houston, the temperature was colder than Anchorage for 48 hours. So, but there is no ski over there. Okay, before the clock starts clicking, I'm not sure if I'm having what I need to have here. Anyway, HER2 positive breast cancer tumors are usually come with a very poor prognosis, and before the development of anti-HER2 treatments, it really shows that the survival of the patients were, in general, as half as those who were not HER2 positive, and that required really attention. And thanks for the introduction of trastuzumab in the management of these patients that helped improve the control of the disease in metastatic disease and as well as overall survival. But we noticed that in these patients, if untreated with anti-HER2 therapy, more of them would have a recurrence within the first 5 years, and generally in a median of 3 years, they all come back with a recurrence. What happens when we started using the Herceptin in the adjuvant setting? Did we really achieve? I have a problem changing the slides, gentlemen. The slides is not changing. So where are our needs with anti-HER2 therapy were really met? Indeed, I would say very comfortably it did not, because a lot of data suggesting that even after 11 years of follow-up of those patients who received Herceptin in the adjuvant setting, still 1 in 3 may experience a recurrence or die from the disease. So we are very far away from achieving good control of the disease in the adjuvant setting. And both groups of patients, whether they are hormone receptor positive or hormone receptor negative, do have the same issue, although with the HER2 negative, the risk of hormone receptor negative, the risk of recurrence is faster, but definitely it is equivalent in both groups of patients. So the HER2 treatment did not, with Herceptin, did not really offer the full protection. And most of these patients will come back with a distant recurrence, and we know that with distant recurrence, the patients would not do very well with systemic therapy, and majority of them would die secondary to their disease. Even the data from B31 and N9831 also confirmed the HERAT trial, showing that the patients do have significant recurrence at 11 years, and the increment here in excess of 10%, which is a very large number for those patients. And even the rate of death from cancer is very high, exceeding 10%, which indicating that there's still a lot of work need to be done to change the natural history of the disease. So the issue was, would it be giving more trastuzumab is beneficial for the patient? And indeed, in a follow-up of the HER2 trial, where they HERA trial, where they look at 1 year versus 2 years, failed to show that increase of the treatment with trastuzumab in the adjuvant setting from 1 year to 2 years, as indicating in the non-blue graphs showing that it did not help in doing much for these patients. So we know that trastuzumab has plateaued in the management of the adjuvant setting and require thinking outside the box, such as newer drugs or various combinations. And indeed, at this stage, pertuzumab came in the picture and showed to be a very successful management with pertuzumab and trastuzumab, both in the metastatic disease and the neoadjuvant disease, to the point that it's also shown that if you can combine these two drugs in the adjuvant setting, that the patient may benefit. It's a very sound objective for a study like this, but in ways it may not necessarily have achieved the whole objectives of the study, because not all of the patients really did benefit from the combination of the dual inhibition of HER2. Well, the combination of trastuzumab and pertuzumab showed like synergistic effect in inhibiting the HER2, but what's this sound? Is it me or? It showed that when you give the patient adjuvant trastuzumab and the pertuzumab for 1 year, indeed it improved the disease-free survival. However, the benefit was more in the node-positive patients and not in the node-negative. This does not mean that it's not working in the node-negative patients, but definitely maybe a longer follow-up may show some benefits in the future. But based on this data, and very recently, like it's a matter of maybe a couple of weeks ago, it was approved in the adjuvant setting for breast cancer node-positive patients, and actually we started implementing it at MD Anderson in our treatment plans for these patients. So now it's considered that pertuzumab, in addition to trastuzumab, in HER2 amplified patients is a viable option and need to be discussed with the patient. Again, this is come at a risk of increased side effects such as diarrhea, but fortunately not of cardiac side effects. Are there other options now than the standard of 1 year of trastuzumab, which is recently changed in node-positive patients to a combination of trastuzumab and pertuzumab? You all remember the ALTO trial, and this is data was discussed in last ASCO, looking at trastuzumab single agent versus trastuzumab with lapatinib, either concomitant or sequential treatment in the adjuvant setting. Many, according to the study design, may be given concomitantly with chemotherapy and finished later, or give the anti-HER2 therapy after the chemotherapy is finished, and the chemotherapy can be anthracycline-based or non-anthracycline-based. The bottom line of this study is showing that trastuzumab versus trastuzumab followed by lapatinib versus by lapatinib and trastuzumab were all equivalent in disease-free survival. In other words, the combination of trastuzumab and lapatinib really did not break the code for these patients. So for those who really wanted, quote-unquote, to be aggressive and want to give them more blockade, lapatinib may not necessarily be the proper choice. However, pertuzumab was the proper choice, and this shows more detailed data of sequential versus concurrent treatment of the trastuzumab and lapatinib versus trastuzumab alone, again showing no significant difference between the three arms, as well as we see that in the hormone receptors did not show a difference, although more and more evidence is being looked at the interaction between hormone receptors and HER2, yet we're not sure of the bottom line of this interaction. Overall survival did not change between the three arms, indicating that the combination of trastuzumab and lapatinib may not be necessarily in the for the advantage of the patients. Another trial, and thanks to Dr. Fahram Becker, who allowed me to present this data, which was presented in San Antonio 3 weeks ago or 4 weeks ago, looking at patients who are HER2 negative and treated with trastuzumab. Would there be any benefit for those patients. We know there's a lot of science are behind this trial. Not only that, even at MD Anderson, we're looking at a trial giving a vaccine for HER2 and negative patients using anti-HER2 monoclonal antibody. And this theory comes on the heels of the B31 and 9831 that showed that significant improvement in disease-free survival with giving the adjuvant Herceptin. No news here, but the news is that about 10% of these patients were HER2 negative, and detailed analysis of those patients showed that they indeed benefited from the Herceptin. So it was counterintuitive why a HER2 negative patient would benefit from anti-HER2, and therefore came the design of this study looking at HER2 negative patients and giving chemotherapy as well as anti-HER2 for 1 year. The HER2 status was considered 1+, and if 2+, it should be non-amplified with a ratio less than 2 or less than 4 copies. 3,200 patients were included in this study, and indeed it showed that there is no difference in disease-free survival, indicating that in the earlier data that were published in at least 2 studies showing that there is some benefit from giving anti-HER2 therapy for HER2 negative patients could not be confirmed in this study. And then when they looked at all clinical entities that you can think of and are all listed here, all did not show any difference between the group of patients that received Herceptin and the other group that did not receive Herceptin. Also, it did not affect the overall survival of the patient. So I think this is sufficient evidence to convince some who really believe that we need to give anti-HER2 to everybody, that it should not be practiced after this very large study. The other drug that was being developed in the patients with HER2 positive, hopefully that they will improve the patient disease-free survival and eventually overall survival, is a relatively newer drug called neratinib, which is an oral tyrosine kinase inhibitor of HER1, 2, and 4. It decreases the HER2 autophosphorylation, and in phase 2 trials, it showed that it has some activity both in treated and untreated trastuzumab patients with a overall response rate of 24 and 56% respectively. Actually, this drug was initially being studied in HER2 positive tumors with the metastasis to the brain, but it moved on to be used as a maintenance therapy in HER2 positive patients. And this study that was published almost a year ago, looking at neratinib after trastuzumab and looking at 2-year follow-up for disease-free survival, as well as 5-year follow-up for disease-free survival, showing that at 2 years there was a difference improvement in disease-free survival by 2.9%. And remember, this is on top of Herceptin versus placebo. And the invasive disease also was neuromically less in the neratinib arm versus the placebo arm, 3.7 versus 5.1. And there were, however, differences in patients who were hormone receptor positive versus hormone receptor negative, indicating that, and again, not understood why, that patients who are hormone receptor positive did better or get more benefit from neratinib than the HER2 negative. And there was recently a great debate in my department trying to figure out why this happened and how to use this drug. And has it not been for diarrhea, it would be widely used in patients. But at this point in time, we are selecting our patients who are hormone receptor positive to give them after 1 year of trastuzumab, another year of neratinib. And we hope that also we can control diarrhea, which is a major problem with this drug, and one of my colleagues is running in a national trial to see how we can prevent diarrhea with this drug. The 5-year invasive disease-free survival also was in favor of narative arm, and the same delta of 2.5%. It means that the benefit continued after 2 years to 5 years, and which had been a very good response. And now we're looking at or awaiting anxiously the data of TDM1 Caitlin trial. Hopefully also will add some additional benefits for these patients, and therefore what we know from now is 1 year of trastuzumab is definitely beneficial. Adding pertuzumab indeed help improve on disease-free survival, and but mainly in node-positive patients. Naratinib indeed help in invasive control of invasive disease, but mainly in hormone receptor positive patients. And Caitlin might give us additional benefits and need to be awaiting the results. And thank you for the time.
Thank you, Professor Nuhad Ibrahim from USA for these lectures. And now again with Professor Banu Iran in neoadjuvant and adjuvant therapy in triple-negative breast cancer. When is more better and when is less enough?
Come, I'm closing it.
Thank you very much. So I apologize. This is the talk from yesterday because of the weather conditions. As Dr. Ibrahim mentioned, we were not able to make it. So this is my lecture from yesterday, talking about neoadjuvant and adjuvant therapy in triple-negative breast cancer, when more is better and less is enough. Again, to advance the slides. Can you guys help me? Okay. All right. So what I would like to do is talk just briefly about adjuvant therapy, neoadjuvant therapy, and then also the post-neoadjuvant kind of extended adjuvant therapy. Because of the time, as well as Dr. Joyce O'Shaughnessy's presentation yesterday, I will not go into the biology of triple-negative breast cancer and its heterogeneity, because you all have seen that yesterday. So I will jump right into the data. So we all know that prognosis for triple-negative breast cancer is not good, even though we know that upfront, initially, it tends to respond well to chemotherapy. And because unlike HER2 positive and hormone receptor positive breast cancer, where we can use endocrine therapy and anti-HER2 therapy, we really don't have that luxury for triple-negative breast cancer. And therefore, the NCCN, as well as ESMO guidelines in the adjuvant setting, actually recommend third-generation chemotherapy with anthracyclines and taxanes. But we also know, and I have to point out that this recommendation is not really based on large, long-term prospective phase 3 data. In fact, there is really a lack of robust prospective data in triple-negative breast cancer for this specific population. And most of the data we have is actually retrospective exploratory subgroup analysis of the triple-negative breast cancer group in large trials that were done and then reported. But these trials, when you do the subgroup analysis, do show benefit from anthracyclines and taxanes. And just to give you an example in one slide, these are, for example, adjuvant and neoadjuvant trials. They were done in the whole breast cancer population, but the subgroup triple-negative breast cancer analysis, and as you can see, the numbers are small. It's 157, 166, do show a benefit from anthracycline therapy. And the same thing also for the taxanes. The addition of taxanes or treatment with taxanes, again, when you do a subgroup of analysis of prospectively run trials, you see that there's a benefit, and hence the initial conclusions that taxanes and anthracyclines is recommended for the adjuvant therapy of triple-negative breast cancer. But the question is also, since we don't have the luxury of using endocrine therapy or HER2 therapy, how do we approach smaller T1A, T1B triple-negative breast cancers? And in general, we know that these tumors, in general for breast cancer, have an excellent prognosis. The breast cancer specific survival at 10 years exceeds actually more than 95% for these T1A and T1B cancers. But we also know that the outcome, this good outcome, can change by the subtype of cancers, especially triple-negative breast cancer. And therefore, the effect of adjuvant chemotherapy in this smaller subset of triple-negative breast cancer is unclear and remains unknown. A recent NCCN study, actually a recent study that was done in the NCCN centers, so data was sent from the NCCN centers of 370 patients with triple-negative breast cancer, the 5-year distant relapse-free survival for T1A triple-negative breast cancers were 93% without chemo, and it increased to 100% with chemotherapy. For T1B triple-negative breast cancers, the 5-year distant relapse-free survival was 90%, that increased to 96% with chemotherapy. This was recently published by Vas Lewis in JCO. But these are not prospective data, so the patients were not randomized. They just retrospectively looked at the data and then determined patients who got chemo and not, and then the outcome. Another, again, retrospective data, not prospective data, that was reported by Ho, actually looked at two things. It looked at the outcome, comparing T1As and T1Bs in terms of local recurrence and distant-free recurrence in those two graphs. And as you can see, there was really no major difference in their disease-free survivals, but the number is small, 194. They also looked at the effect of chemotherapy in this cohort, but again, patients were not prospectively randomized. They just did the retrospective analysis amongst people who received it and who didn't. And of course, there's a lot of bias. But what they've shown is that, again, the upper part is for the local disease-free survival, and then the lower part is for the distant disease-free survival. It appears that in these T1A and T1B tumors, chemotherapy really does not have a major effect. But again, retrospective analysis. However, there is another data set that is much larger. It's from the National Cancer Database. It was presented as an abstract, the paper I haven't seen yet, so I don't have the results, but it's a large cohort. And again, nobody was prospectively randomized, but that kind of shows the opposite of the previous study I have presented. So they also looked at two things. They looked at survival, and they also looked at the benefit of chemotherapy. So first of all, when they took the T1As as a reference, the hazard ratio for death for T1Bs was 1.43, and for the T1Cs was 3. So the prognosis is less when you increase from T1As to Bs and then Cs. They also looked at the 4-year overall survival benefit from chemotherapy in the T1Bs and T1Cs and As also. So with adjuvant chemotherapy in T1Bs, the survival was 97 with chemo versus 92 without. And in the T1Cs, the 4-year overall survival was 94 with chemo and 80 without chemo, and that was statistically significant, but again, not prospectively randomized studies. And this study also showed, or their analysis also showed, that there was no benefit from chemo in T1A tumors. So this is a little bit different results than the previous two studies. So therefore, the NCCN actually recommends no chemotherapy for triple-negative breast cancer in T1As. In T1Bs, it can be considered, and I think we are all now facing 6 millimeter, 7 millimeter, even 5 millimeter tumors with triple-negative breast cancer in young women that we are discussing at our tumor boards, should we give chemo or not? And we are increasingly treating more of these patients with anthracyclines and taxanes, and sometimes with TC. And for T1C tumors, for triple-negative, there's by NCCN strong recommendation to do third-generation chemotherapy. So if possible, we offer anthracyclines and taxanes to all of those patients. So how about neoadjuvant chemotherapy for triple-negative breast cancer? So we know that a high proliferating tumors such as triple-negative breast cancer and HER2-positive breast cancer respond much better, have a higher PCR compared with luminal tumors, for example. The neoadjuvant setting also gives us an opportunity to assess response, activity of either new targeted agents or combination chemotherapies or other combination targeted agents to be studied in vivo in a much shorter time than with adjuvant trials. And in fact, large pooled analysis of clinical trials in the neoadjuvant setting, again, many of them doing subgroup analyses, showed that, that if you achieve a PCR in triple-negative breast cancer, event-free survival and overall survival is prolonged. And this is just one example from our institution. Liedtke et al. Had looked at the PCR rate in our cohort and identified that the PCR rate was about 22% for the triple-negative population, and the non-triple-negative was 11%. So kind of in line with what's reported in the literature, that the triple-negative breast cancer patients have a better PCR. The other interesting finding was what predicted the survival was actually achieving a PCR, whether you've had triple-negative breast cancer or not. So that was, so being triple-negative or not, as long as you achieve a PCR was good. But if you don't achieve a PCR and have triple-negative breast cancer, those patients really do bad, whereas patients who don't achieve a PCR but don't have triple-negative breast cancer. So if you have triple-negative breast cancer and respond, have a good PCR, you do well. But if not, that's the worst group, actually. And again, numerous clinical follow-up trials have shown that also. And this is just a summary, of course, because of the interest of time, I will not go through, but neoadjuvant trials using anthracyclines or anthracyclines with taxanes in the neoadjuvant setting. And these trials are not done in the triple-negative subgroup. They were done in larger cohorts, but these trials reported also in the triple-negative subgroup. So we have that information indirectly in subgroup analyses. But not all, but many show that in the triple-negative subgroup, like in ours, the PCR rate is much higher than the rest of the non-triple-negative patients, as you can see in the JEPAR Duo, JEPAR Trio, and the other EORTC studies and so forth. So what we can say is that overall the PCR rates in triple-negative breast cancer can range anywhere from 25 to 40% with taxane and anthracycline-based regimens. But, of course, that's not enough, especially knowing that the triple-negative breast cancer patients who don't achieve a PCR have a horrible prognosis. So right now, a lot of effort is put into improving PCR rate with additional agents, in addition to taxanes and anthracyclines. And, of course, the famous agents, again, what I had discussed for the BRCA mutation carriers is platinums. There are also studies looking at bevacizumab and other chemotherapeutic agents, but also targeted agents, PARP inhibitors, PI3 kinase inhibitors, everolimus, either as single agents or mostly in combination with chemotherapy. So I want to just very briefly mention three neoadjuvant trials that was specifically done in the triple-negative breast cancer subgroup. Again, remember, all of the slides I've shown is in the whole breast cancer population, and they analyzed in a exploratory fashion the triple-negative subgroup. But these are in triple-negative breast cancer patients. So, and you know the results. It's not new, but the JEPAR-6, though, looked at the addition of platinums to anthracyclines and taxanes in the neoadjuvant setting. The PCR rate was significantly increased from 37 to